This screencast will be about the basic principles of research ethics. And we're going to go over a lot of the information that was discussed in the CITI or CITI training, although this screencast will hopefully take an approach of looking at the forest as a whole rather than at the trees, which in my opinion is what the CITI training does. It gives you a lot of information about trees. Well, individual documents and stuff within research ethics, not actual trees. So we're going to talk in this screencast about the three basic principles of research ethics, which are respect for persons, beneficence, which is a difficult word to say, and justice. We'll talk first about respect for persons, or the idea of essentially treating research participants as we would wish to be treated while being attentive to the power differential between researchers and research participants, which is, very strongly correlates, I think, to the power differential between social workers and their clients. The next principle we'll talk about is that one that's difficult to say, beneficence, which is the idea that people participating in research stand to gain from the results of the research, either individually or collectively as a community, as members of communities that they represent. And the last principle we'll talk about is justice, or the idea that both the burden and benefit of research are shared equally across communities. So first I'll talk, though, a little bit about what research ethics are and a little bit about the Institutional Review Board. So research ethics are essentially a set of standards or agreement regarding how research should be conducted and what kind of oversight and accountability we should have. A lot of these guidelines are really common sense, like you can't do unnecessary surgery on people to see what happens. You can't give pregnant people unknown medications to see what happens to their fetuses. And so I think sometimes, because so many of the research ethics and guidelines are such common sense, it can feel a little bit redundant or even condescending or insulting that we have these guidelines telling you, don't sleep with your clients. But the reality is that most of these guidelines were created in response to research abuses, some of which we'll discuss in the next screencast and also in class. And all these research abuses, I really believe, were committed by very well-intentioned people, which I think who were pursuing scientific knowledge or attempting to solve problems facing humanity. So I think this really speaks to the idea that there's a lot of gray areas, and as a species, human beings are very good at justifying stuff to ourselves. And the fact that all these abuses, where really common sense protections for human rights weren't respected, speak to the need, I think, for regulations and standards. So yeah, and I think another point to keep in mind is that there's a lot of inherent power imbalances built into our society. And because of these power imbalances, one of the results sometimes is, unfortunately, that people's humanity are devalued by researchers. And again, we've had some really, really egregious research abuses, including recently. So some of these examples, Tuskegee was a study that ended in, I believe, 1976, the mid-70s. The Guatemalan STD study, though, continued long after Tuskegee and only came to light very recently. And again, we'll talk about that in a future screencast. And I have to say, as a researcher now, I've definitely heard of several ongoing modern research abuses and things that really, I think, should give researchers pause. So again, as much as we might not, so much of what we're about to talk about seems like common sense, I think there really is a need for these rules and regulations. So the CITI training goes over some of the documents that are important in research regulations. The first one, I believe, was the Nuremberg Code, which came out of the Nuremberg trials, which were trials of Nazis, including Nazi scientists and physicians, who performed a lot of experiments on people who were incarcerated, essentially, in concentration camps. So the Nuremberg Code was a document that came out of these trials and outlined some basic guidelines for research. The Research Act of 1974 passed right after the Tuskegee syphilis study came to light. It didn't shut down for another few years. And along the same time period, the Belmont Report was a document that talks about the difference between providing services or care to someone and conducting research, because they are different. And we'll talk about this when we talk about respect for persons. And the Belmont Report was the first document that articulated these three principles that we're going to be spending most of the time in this screencast on: respect for persons, beneficence, and justice. And the Common Rule is an administrative document that standardized regulations for research across all government agencies in the United States. So one of our research guidelines in the United States that was standardized by the Common Rule is the presence of institutional review boards, or IRBs. And so any university or other institution that conducts research needs to have what's called an institutional review board, which is an in-house team of volunteers who meet periodically to review research proposals by members of that institution. And all research that's conducted in the United States needs to be reviewed, approved, and monitored by the Institutional Review Board. And so this is, institutional review boards are a way of organizing the fact that there's, at least tens of thousands of researchers in the United States. So having everyone apply to a single government body would just get really complicated and time consuming. So this way people apply to the Institutional Review Board within their institution. And all institutional review boards follow the same guidelines, which are set out by the federal government and are actually part of statutory regulation. So, okay, with that background in mind, I'm going to talk about the first of the three ethical principles: respect for persons. The way I think about this really also includes respect for communities and an acknowledgement of the person in context. So how do we respect not just the individual participant, but the community that individual participant belongs to? And how do we do this in an intersectional way? That's my definition, though. Federally and within the Belmont Report, this is a very individual-focused idea. So treating every individual with respect, as we would ourselves want to be treated. And there's several different ways we do this in research. The first one is confidentiality. So doing what's called de-identifying data. So going through and taking out anything that might let us know who someone is or identify them. So, not listing a birth year or an age range rather than their actual birthday, assigning them a code name to be used in place of their name, stuff like that. That being said, some people are still recognizable even if we change their identities. They're well known, their work is well known, they have a rare condition that makes them recognizable. So really working with people to get permission to share anything about them or anything that could potentially be identifiable, and making sure they really understand how you'll maintain confidentiality and what the risks are. That participating in research does always entail some risk to confidentiality, even if we're doing perfect de-identification. Who's to say my computer doesn't get hacked tomorrow, which hopefully doesn't happen. Hackers will be looking at a lot of pictures of my dog. But, really making sure people understand the limits of confidentiality as well. And some ways to do this are within data analysis, um, in a lot of participatory methods, we actually, because we're working in teams, in collaboration and partnership with people who aren't researchers by training, who would traditionally be thought of as research participants, um, we just ask everyone on the team how they want to be identified or not. Do they prefer to use their first name, their full name, or be given a pseudonym and have their identifying details changed? Again, there's some people who are always recognizable. And then in terms of data analysis too, are we, even if we're maintaining confidentiality, does something about our analysis identify people? Or are we presenting inaccurate information? Are we representing the community well and accurately and equitably and respectfully? Another example of how confidentiality can be compromised is in the dissemination or sharing stage of research. So this is after you've collected and analyzed your data. And research is only as good as the people it reaches. So I can do brilliant research that just stays on my desk forever, and it won't be very impactful unless you happen to be in my apartment looking at the scrawled notes I have to myself on my desk. So we really try to share research so it can be meaningful. That being said, so this is a true story. I once did a study of reproductive and sexual health for young adults. I believe people were between 18 and 25. For young adults with intellectual and developmental disabilities. And we did some of our recruiting through an agency that provided different kinds of services to people with intellectual disabilities. And they had a lot of career and transition to adulthood focused programming. So we advertised the study within this program to try to find people who were willing to be interviewed. So we did our study, we found some results, including the fact that most of the young adults I interviewed were sexually active and weren't sharing that information with their parents for, multiple valid reasons. So that happened. Our study was, done and getting ready to be disseminated and shared. When I got invited, so this agency also had a parent support group for parents of these young adults. And so I got invited to speak to the parent support group about sexual health for young adults with intellectual and developmental disabilities. And as you can imagine, this really involved an ethical dilemma because my findings were many young adults with intellectual disabilities are sexually active and they don't feel comfortable talking to their parents about it. However, many of the young adults who had participated in my study lived with their parents or, hung out with their parents at times and mentioned that a researcher had come and with their permission interviewed them about their sexual and reproductive health care needs. So parents were well aware if their adult child had spoken with me or not. So were I to get up there and say, well, according to my 13 anonymous sources, young adults with intellectual disabilities are often sexually active, I think I would have caused some family problems, as well as really violating the confidentiality of the people who had graciously allowed me to interview them and were trusting me to maintain their confidentiality. We ended up waiting a little bit to publish our findings and then publishing them in a very de-identified way, but also in a way that wasn't immediately traceable to our research team. And I declined the invitation to speak at the support group. Recommended a colleague who had not, to my knowledge, interviewed the support group's members' actual children. So another thing that's discussed under respect for persons is this idea of vulnerable populations. And so federal regulation defines vulnerable populations as the following 3 to 4 groups, depending on if you consider fetuses a separate group. But pregnant people out of, concern about impact of particularly biomedical research on fetuses, people who are incarcerated, and children. So according to the federal government, these are the three groups of people, four if you count the fetuses, who are vulnerable to the harms of research and need special protections to ensure their human rights. In real life, in my experience, and a lot of the more modern scholarship around this topic, vulnerability is much more complicated than a list of four groups. And so the way I think about it, and there's some research also thinking about it in this manner, vulnerability having to do with power imbalances and who is on the end of the power imbalance with less power. That in some way constitutes vulnerability. And there's a historical aspect too, so what historical conditions create vulnerability to being disenfranchised in research, what historical oppression might be at play and continuing to influence our modern society. Vulnerability can be about one's identity. So I'm a woman versus situational. So in the context of being in my doctor's office or being terminally ill or incarcerated, those situations aren't aspects of my identity necessarily. I might be vulnerable in the context of an interaction with my doctor. My doctor has power over me, but I might not be as vulnerable in an interaction with my partner, my friend, or my child. And I might actually have power over someone in a different situation, like an interaction with my client. So who's really vulnerable? And is vulnerability based on an identity, like being a child? Or is it situational, being incarcerated? And do we always know who's vulnerable? Do we know who's living with violence? Do we know who's undocumented? Do we know who has an invisible disability that might impact their potential for being coerced? We don't always know. And who gets to decide who's vulnerable is in and of itself a question of power. There's a lot of power differentials that go into, for example, my ability to determine whether or not someone's vulnerable and why my say is more important than their say. And am I really the right person as a researcher to be determining someone's vulnerability? I obviously have a stake in the issue and an agenda of my own as a researcher. And this idea that vulnerability sometimes changes over time. So perhaps people are vulnerable at the stage of the project when we're recruiting participants. They're vulnerable to coercive practices, but as time goes on, once they've made the informed, truly informed decision to participate in the study, they might not be vulnerable to the part of the study where we're analyzing their data. Vulnerability can also change over time, whether by circumstance, individual circumstance. So I'm now living with domestic violence, and so I'm more vulnerable than I was at the start of the study. And also with political circumstances. So I think I've talked about this before. I have a friend who does a lot of research related to the health of people who are immigrants and their access to health care. So right now, politically, the groups and communities that my friend works with to do her research are much more vulnerable than they were, 2 years ago when she started a study based on changes in our political landscape. So that being said, vulnerability is not a straightforward concept, I don't think, or shouldn't be. I mean, we should be making really thoughtful, engaging in really thoughtful conversations about what constitutes vulnerability. But protecting people who might be vulnerable or have the possibility of being vulnerable to human rights abuses and ensuring that our research isn't making people vulnerable, isn't putting people at risk of vulnerability, of coercion, of having their human rights messed with. We need to consider this at every stage of the research process, and we need to consider it in a community-informed way. So not just, there are children in this community, and children are vulnerable to abuses and coercion. But what are the specific risks facing these specific children in the context of this community? What larger political forces and social forces are at play that change vulnerability in very sort of individualized and unique and context-specific ways? So here are some groups that might face particular risks. So I'll, give you a few minutes. You can pause if you want to think about the risks that people who are members of the following group might face in the context of participating in research. Why is it that people who are incarcerated might be more vulnerable to abuses of their human rights in research? And the same for these various groups, people with disabilities, refugees, people living with violence, parents who are involved with DCF, Child Protective Services, and in particular the population, people receiving social work services, and in particular the population that you're planning to work with in your research project you're designing for your final assignment. What are the specific historical, contextual risks or vulnerabilities or systems of oppression that impact this community, and how does that translate to a research context? So another aspect of respect for persons, which I mentioned briefly, is this idea of differentiating between practice, providing clinical services, and research, doing things to increase scientific knowledge about something. Because there can be some real potential and actual conflicts between research and practice. So if I'm a physician and I'm or a biomedical researcher and I'm developing a new treatment for cancer, right? And we all agree that's good and important work. I have a very vested interest in taking this potential new treatment through the process and evaluating it and getting it into circulation so that I can help people. However, if I was also a physician treating patients, there might be a conflict of interest in that I would want to test this brand new treatment as much as I could. I really believe in its ability to help people. So I might start giving this treatment to some of my patients, whether or not it was right for them. And I also might not sufficiently explain to or clarify for my patients that some of the treatments I'm giving them have already been evaluated and are evidence-based. And this one treatment is my brand new research that hasn't been evaluated yet, and we don't know enough about it. So one thing I thought about a lot when I did research, when I worked at Boston Medical Center as a researcher, was thinking about where I did my research activities. So if I was going to interview someone, would I have them about their access to primary care and what some of the issues are for people with lived experience of mental health conditions in accessing primary care? Why does this group get less primary care and have more preventable poor health outcomes? So if I was going to interview someone about that topic, did I want them to come to the hospital and be interviewed in one of our conference rooms? Or did I want to go to their house or meet them at a Dunkin' Donuts near their house? Because when they came to the hospital, there was a risk that they would assume that they were getting some type of health care. It might be easy to have what's called the therapeutic misconception, or the idea that by participating in research, they were getting health care, even though in actuality there weren't. There's nothing that helps, that's being interviewed by me is in no way beneficial to your health. So a place that issues around respect for persons often come up is in the recruitment process, or the process of finding people to participate in your study and getting them interested. So poverty, I think, places people in a place of potential vulnerability to coercion, in that many research studies offer incentives for participation. So, if I spend an hour of your time interviewing you, I will give you a $25 gift gift card to Target or Amazon or whatever. Which I think is really important. You know, people's time is valuable and compensating them for their time is valuable. That being said, I always disagreed with this. So I've worked on some studies where we interviewed physicians. And at Boston Medical Center, the Institutional Review Board felt that in general, $25 was a good incentive amount for people who weren't physicians. But for people who were physicians, because physicians make a lot of money, maybe not primary care physicians, but I'm thinking in particular of a project I did interviewing a specialist, a very highly paid specialist field of physicians. So we would get approved to routinely offer physicians $50 or $75 gift certificates. Personally, I think everyone's time is equally valuable. If we're paying people in the general population $25, I think should be the same. For very highly paid doctors, they certainly don't need the extra money. But the concern was coercion. So if I'm really struggling to make my rent, and someone's offering me $75 or $100 or more to participate in a research study, regardless of whether I want to participate in that research study, I might choose to anyway because I need the $100 in a way that our overpaid specialist physicians might not need that $100. So that's an example of coercion. Another kind of coercion that I often ran into in the recruitment process, in working with historically oppressed members of historically oppressed populations and populations currently experiencing a lot of oppression, was this desire to belong. So if we were doing a research study about a topic that impacts everyone equally, people living with a lot of oppression might feel coerced to participate in that as a way of almost proving their humanity as a result of having been conditioned, unfortunately, or often asked repeatedly in society in their interactions with a world with a lot of structural oppression to prove their humanity. So that's something I think to really be sensitive to. Another thing I think about a lot in some of my research, particularly with autistic adults, is that some of, and particularly, autistic adults who are on the older side of adulthood, many of the so-called treatments used back in the day and sometimes that continue to be used really taught people to obey orders, so there was a lot of manipulation and coercion in people's childhoods around saying yes to people, doing what was asked of you as opposed to what you wanted. So that's something I think about a lot in my own research with autistic adults, many of whom are my age or older, and so were exposed to fairly traumatic coercion-based therapies. You can't see my air quotes, but I'm using them. So that's something to think about in recruitment too, and kind of plan around to make sure that we're doing everything we can to avoid coercing people. A final element of respect for persons is this idea of informed consent. Making sure that people have all the information they need to make a decision about if they want to participate in research, and not doing any research activities at all without people's explicit informed consent. This is going to be a midwife example, but I think oftentimes how we do consent, and we've talked about this before, is very different from how we should be doing consent. So here's an actual quote from many times I, was in the hospital when someone was giving birth or was in labor. So saying to someone, I'm going to induce your labor. The risks are XYZ, but you should do it. You should allow me to artificially speed up or begin the process of your labor. because all these compelling reasons, and also you don't want your baby to die, do you? So it's sort of a, a threat or a way of inducing fear that can be coercive. Versus, a more choice-based model of you have the option to have your labor induced, which would be done by XYZ. Here's some real details about the process. The benefits of this option are X, the risks of this are Y, and your other options include XYZ. What do you want to do? So that's a very different way of presenting informed consent, and that's absolutely what should be happening in research. And we also need to have processes in place for determining what's called capacity to consent. So, if you ask a 4-year, if you gave that little speech about you have the option to have your labor induced, or that's a bad example with children, but something like that to a young child, a 3-year-old child, they might say yes or no, but we could, and you probably know this better than me, developmentally, does that child really have the capacity to make a true decision and provide meaningful consent? So we need to have a process for evaluating this. So these are all the elements of informed consent, and really all of these need to be included in informed consent for research. So what's the purpose of the research? What's the procedure for the research? What will we do? How long will it take? What will you do at different stages? What the risks are to participating in this research? And how we as a research team will minimize or manage the risk, though we can never guarantee that there will be no risks. There's always risks. Are there any benefits either to that individual? So for example, in a study I did where we were evaluating the efficacy of an educational DVD, one benefit was that the individual person might learn more about the topic that this educational DVD was about. And then on a larger level, on a kind of a community level, there might be some benefits to groups that this person is a member of. And there might be a benefit to kind of science in general or society in general. What are the alternatives to participating in this study? What choices does a person have? What are the risks to confidentiality, and how will we protect as best as we can? And again, we can't make guarantees. How will we protect confidentiality and store their information? Who will we share it with, and how? Will they have any costs? I mean, do they have to pay to park if they're coming to a hospital or a clinical site to be interviewed or to participate? Will they have to pay for childcare? Will we compensate them in any way? We need to make really clear that participating in research is voluntary, and that they have rights as research participants, as well as, the rights that all of us have as human beings. And we need to make sure that that we've answered all their questions. We need to give them opportunity to ask questions and make sure we've thoroughly answered their questions in the way that they understand. And there's some special considerations in informed consent. Children, people who have legal guardians, which is a specific arrangement made for a person with cognitive limitations of some kind, in which they've undergone an extensive evaluation of their decision-making capabilities, and a judge has assigned a specific individual to help them make decisions because the judge feels that they can't, that they need support to make decisions. So not every person with a cognitive limitation has a legal guardian. In fact, most don't. But if someone has a legal guardian, an adult has a legal guardian for the reasons I described, or a child has a parent or legal guardian, that person who's actually participating in the research would give what's called assent, which means they've heard about the research, they've heard about the risks, and they've agreed to do it. And their parent or guardian would give formal legal informed consent. That being said, I think we need to think about who gets to define capable of giving informed consent, and what does that really mean, versus how can we adapt and make accessible the information and the process of informed consent and informed choice to really promote informed decisions and human rights. So a technique I sometimes used in doing research with people with cognitive limitations is I would use what's called a consent quiz. So this isn't a formal quiz, but basically I explain the different elements of the project and then ask them to explain back to me in their own words, just to ensure that they understand. A final thing that I don't believe the city training talks about, but I think is especially relevant to you as social workers, is the idea of abuse reporting. So you're a mandated reporter as a social worker, which means if you witness abuse or neglect of a child, an elder, or a person with disabilities, you need to report it to the appropriate agency or governing body or authority. And I really think research participants have a right to know that. So these are both things that have happened either to me or to colleagues. So if you're interviewing a participant in her home and you see the participant's sister abusing their elderly father, you're mandated to report that. And I think before you begin interviewing anyone in their home or in any other location where you might witness abuse or neglect or be told of abuse or neglect, the participant needs to know that and make a decision about if they want to participate, knowing that you are a mandated reporter. If someone, and this has happened to me in a different context, that I was conducting a focus group and someone disclosed in the group that they were living with intimate partner violence. And I had just finished talking about how this focus group was a safe space and people can share as they feel comfortable. And at the time, I worked in a role where I was a mandated reporter. There was a child who was, witnessing this interpersonal violence. And so I had a very long discussion with that. I interrupted the person before they provided more details and said, I just want to remind you that I'm a mandated reporter. You haven't said anything yet about, but I know you're a parent. You haven't said anything yet about the child witnessing or being around or being victimized by your partner who is violent towards you. But if you say anything about that, because of my job and the fact that I'm a mandated reporter, I would need to notify DCF. So I want you to have that in mind as you make choices about what to share. And at that point, the participant made the decision to stop sharing. And I think that's, really valid and important that people, again, are getting to make that decision. Because when you're conducting research, you're not there in your role as a social worker. Going back to the therapeutic misconception, you're not practicing, you're doing research. Okay, so that is respect for persons, and I promise my discussion of beneficence and justice will be much shorter. So beneficence is the idea that people who participate in the study, in your research, at least have the potential, there's a potential that they might benefit from this research. Whether on an individual level, for example, in biomedical studies, perhaps the treatment that we're testing, that we're doing a clinical trial of, works. Or in my educational video example, perhaps they learn more about the topic. And there needs to be there could also be potential for benefit to society that will in turn benefit them. So I'm currently in the planning stages of a study looking at the needs of parents with intellectual, developmental, and psychiatric disabilities and how healthcare providers and child welfare workers can better meet those needs. And likely the people who participate in my study won't have any benefit to themselves personally. But one of the goals of the study I'm planning is to create some tools for in the future parents with disabilities to advocate for themselves and their families in the context of healthcare and child welfare. And so that might benefit not my individual participants, because it'll be a few years, to do this research and develop these tools, but it might benefit other members of a group that they're part of, in this case parents with disabilities. A concept that comes into play here is the idea of equilibrium, which is called equipoise in biomedical research. So the idea that when you're in equipoise, the potential for harm and the potential for good are equal. If we learn that the potential for harm is greater than the potential for good, it can become unethical to withhold treatment from people in the control group. So an example of that is one of the breast cancer drugs. I want to say Herceptin, but I'm not completely sure. So they were doing a long-term clinical trial of this breast cancer drug that was designed to prevent, once someone had already been successfully treated for breast cancer. They took this drug for 5 years with certain kinds of breast cancers. They took this drug for 5 years in hopes of preventing a recurrence. And about halfway through the study, they saw that people in the group who got this medication were having so many fewer reoccurrences of cancer that it was unethical to have people in the control group who weren't taking this medication. It became unethical to not give people in the control group this medication to prevent reoccurrence. So that's an example of when there stopped being equipoise because the experimental group was having such significantly better outcomes than the control group. It should be noted, though, that just because there's a potential for benefit doesn't mean that people or communities will benefit, just so that it's possible, so that that equation between risk and benefit is in equipoise or equilibrium. Okay, so the last ethical principle we're going to talk about is justice. And broadly, this is the idea that we're sharing equitably the burdens and the benefits of research. So this is an important principle because in so many studies, up until very recently, it was rare to find justice. We have a lot of research abuses where we experiment on one population who bears the burden of research. They're exposed to all the risks of research. And then we use what we learned in that study to benefit a different population. So one of my favorite books, I mean, it's not like a light beach read, but one of the books that really informs my practice and my way of doing research is called Medical Apartheid. And it's a book that talks about the long history of experimenting in very coercive ways on people of color in order to generate knowledge about medicine and science that was used to benefit white people. So used in ways that, for example, the knowledge gained through research on people of color was taken to segregated hospitals that people of color couldn't access, so that it benefited white people who had access to those segregated hospitals and didn't benefit the people who had borne the risks of research. And we'll talk in class and a little bit in another screencast about the Puerto Rican contraception study, or the big clinical trial of hormonal birth control, estrogen-based hormonal birth control, that really brought the pill to the United States, and all the research that was done on people in Puerto Rico, often without their knowledge or consent. They were just given these pills and told to take them. So again, they bore the risks and the burden of the research, but not the benefits, because once it was proven that the pill worked, it was taken to the mainland US and marketed there. So this principle of justice, and so that's obviously really a problem, right? To have people in Puerto Rico bearing the burdens of research about contraception and then not being able to access contraception because it's being made accessible only to upper class, mostly white women who live in the mainland US. And so this principle of justice is based on the premise that all people's lives are equally valuable and we all have the same human rights. It doesn't vary based on identity, intersections, location, historical circumstances. And so in every study, it's really important to think about how to ensure justice. And assess the risks and benefits really carefully and closely. And in the next screencast, we're going to talk about different strategies for ensuring ethical research and really thinking about how to keep our research ethical and in line with these ethical principles at all stages of the research process. So I will see you next time on the next screencast.